So, thank you everyone for inviting me for this talk, respected chairpersons and the principal of Vishwabharati Medical College. So I'll be talking briefly about the historical aspects of schizophrenia. It is very important for us to know that, because as a lot of chairpersons have alluded to, there are a lot of gaps in our knowledge, and a lot of the times when we treat people with schizophrenia, we find it very difficult to manage primary negative symptoms or cognitive symptoms maybe. And so it's very important to see how our current understanding of schizophrenia has developed. So going on to the topic proper. So schizophrenia, there are hardly any descriptions of schizophrenia earlier, and perhaps one of the earliest descriptions of schizophrenia was in the early 19th century by Philippe Pinel, who was a French physician. And he had actually advocated a more humane and psychological approach to the treatment of mental disorders, the so-called moral therapy. So in this picture, you can see that Pinel is removing all the chains from patients at the Salpêtrière Hospital in Paris. So some people do describe him as a father of modern psychiatry. He perhaps gave one of the earliest descriptions of schizophrenia. But there have been descriptions of schizophrenia prior to Kraepelin. Perhaps one of the first descriptions was by Haslam, and he gave a description of a patient, James Tilly Matthews, and this was perhaps the first description of schizophrenia in British psychiatry. Thereafter, Benedict Morel actually coined the term dementia précoce when he actually described a person with probably symptoms of schizophrenia from France. In fact, Arnold Pick actually has used the term dementia precox much prior to Kraepelin, when he had actually coined the term perhaps in 1896. In 1881, he had given a series of, he had described a series of cases which probably were schizophrenia. So even prior to Kraepelin, there were people who were actually describing symptoms of schizophrenia. And of course, one of the most important this thing is Carl Baum, who described catatonia. So Carl Baum has a lot of important contributions to psychiatry, the actual description of catatonia. Also, he was one of the earliest critics of unitary psychosis. During this time, the popular notion was that psychiatric disorders were a single mental illness with multiple different manifestations, and this was actually developed by the Belgian psychiatrist Wislan and popularized by people like Griesinger and Henrik Newman. But Carl Baum actually was not in favor of this. He also divided into organic and functional psychosis based on his observation that catatonia can be secondary to perhaps primary psychiatric disorders, or maybe secondary to other metabolic disorders or neurological disorders. One of Carl Baum's student, Hecker, had actually described hebephrenia, and they had actually worked at the psychiatric asylum in Gorlitz in Germany. And so Hecker and Carl Baum had worked together and had greatly expanded knowledge. And here is the man himself, Kraepelin. Most people describe him as a father of modern psychiatry, but this is not modern psychiatry. Perhaps he is also, you can describe him as a father of psychopharmacology. He was a student of Flechsig, who had actually described myelinogenesis. He was a neuropathologist, and Wundt, who is the father of experimental psychology. And he brought in forward the dichotomic concept of psychosis, the manic depressive psychosis and the dementia precox. And Kraepelin is always, he had also made a lot of contributions to nosological structure. The current psychiatric nosology is based on how Kraepelin had described syndromes, and it's his principles that we use in the current nosological systems. He was very interested in psychopharmacology. He had used potassium bromide as a sedative. He had experimented with chloroform and different other chemicals for treatment of psychiatric disorders. And he's also actually had a lot of contribution to clinical epidemiological research. He wanted psychiatrists at that time to actually all over the world, and he had traveled to places like Java, many places in Europe, where he, and along with the help of many psychiatrists, have painfully actually noted down the symptoms of the particular disorder for a long time. So if you look at it, he actually formed the first consortium for epidemiological clinical research. So, and other contributions of Kraepelin, he had described after the first German World War symptoms of war neurosis, which was a forerunner of PTSD. So Kraepelin has numerous contributions to psychiatry. However, I mean, there are one of the themes that I wanted to actually present in this small talk with regards to history of schizophrenia is what are the dangers there are there. So apart from all his seminal contributions, it is known that, you know, Kraepelin was someone who had really, so he had described many. So Kraepelin was someone who actually turned increasingly into eugenics and racial hygiene. So I mean, these were perhaps the principles and policies based which on Third Reich and the Nazis had actually, under the leadership of Hitler, had come in. So he was actually a proponent of that. And this is not something that is well known about Kraepelin, but something which I believe that we should be aware of. Because there are two shades to the father of modern psychiatry, and hence the two question marks. He was also a proponent of genetics, but he actually, rather than believing that psychiatric disorders followed a Mendelian inheritance, believed that psychiatric disorders, he was a neo-Lamarckian, where neo-Lamarckians believed that, you know, cultural characteristics were heritable. And so he believed that high culture and life experiences threatened not only to countermand Darwinian laws of natural selection. So there was a dark side to Kraepelin as well. And this is something that I want to actually highlight, apart from all his seminal contributions to psychiatric researches. And over a period of time in the 19th century, the term insanity was replaced by psychosis. And then there would by psychosis. There were many other terminologies for schizophrenia that different people had described. Karl Wernicke-Korsakoff syndrome described it as a junction. Otto Gross, the Meyer-Gross performance, Otto Gross had described it as dementia subjectiva, segmentiva. DM had described a dementia simplex. Stransky had described as intrapsychic ataxia. And I also just want to all of you all to just pay attention to. Hosch had actually given a very, very accurate description of our knowledge of schizophrenia. And I'd just like to read that out. He dismissed the excessive oversight, believed that it was nonsense to try close correlations between specific sites and diseases as psychiatric syndromes. And they were likely to result from collective and synthetic activity of multiple brain sites. And this is what, so he believed that you could not, Hosch believed that you could not localize psychiatric syndromes to specific parts of the brain, but it may be a collection of different sites. And this is what our most recent research with neuroimaging, with fMRI and all the other tools that are there at our disposal shows. So there were many people who are listening. And as somebody said, Karl Jaspers, the father of descriptive psychopathology, and he had described psychiatric illnesses into three groups. In his seminal work, General Psychopathology, he had given the way that psychopathology should describe. And I would just like to read out this quote from Jaspers. He said that for eliciting psychopathology, there must be a tranquil immersion into facts of psychic life without jumping to conclusions. And that's my message to all the students who are there. I don't think we should jump to conclusions based on experience. We must ask questions, as Jaspers has told. As he says, it is our job to learn, to observe, ask questions, analyze, and think in psychopathological terms. So it's a very important quality that we must develop, to ask, to understand the meaning of their symptoms, and what is the logic behind the description of the symptoms. So it's very important for us to understand that. And after this came Bloiler. And Bloiler had coined the term schizophrenia, and he had described basic symptoms, which are the loosening of associations, ambivalence, affective incongruence, and autism, and accessory symptoms, which are delusions, hallucinations, all the other psychotic symptoms. So he had coined the term schizophrenia in 1908. and it is actually derived from the Greek word cuisine, indicating splitting, or Splattung, as they call in German. And the second part from Frem, originally denoting diaphragm, but later changing to soul, spirit, or mind. So, and thoughts of Bloiler had significant impact on how psychiatry was practiced in the US. However, I mean, what are it was from the Preplin's degeneration and dementia precox, the understanding of schizophrenia had shifted to the process of splitting. But there was a lot of criticism. That schizophrenia itself, one of the criticisms of the name is that it is maybe defective and generates an unacceptable number of borderline cases. And that is something that we are true. So we see in our practice, we may see them as attenuated psychosis syndrome, or we have the enlarged schizophrenia spectrum disorders. And also he says that schizophrenia is intrinsically vague. Because no amount of addition of criteria will improve upon its definition or sharpen its boundaries. And it's more or less a construct rather than disease. So since it's heterotypic and there are a lot of symptom dimensions, it's more of a construct rather than a particular disease. So these are some of the criticisms. And this is Kurt Schneider. He was one of Jasper's students who had talked about the first 9 symptoms, which are famous. Other people came in and went. Leonard gave different kinds of. He was the person who introduced the term polarity, perhaps not with the understanding that we have about with the term, but he had divided it into phasic psychosis, cycloid psychosis, and schizophrenic psychosis. So it's based on the onset course Leonard had classified. So I'm just going through this because rushing through this because of the lack of time. And in the US, at this point of time, this gentleman, Adolf Meyer, had brought about the theory of psychobiology, and he had espoused the reaction pattern concept of schizophrenia, more with the psychodynamic underpinnings. And this had actually influenced a lot how psychiatry was practiced in the US for many years. And so what happened because of that, there was a substantial variation in how the diagnosis was made. The rates of psychiatric diagnosis were increased in the US, whereas in the UK, where they followed more of a Kraepelinian kind of diagnostic system, it was more limited, and the prevalence of schizophrenia remained what it was as earlier, but in the US, the rates increased, and it was because of this that the WHO had led these seminal IPSS, the International Pilot Study on Schizophrenia, and later after that international study on schizophrenia, to actually look at these matters. Another important landmark in schizophrenia is perhaps the discovery of the first antipsychotic drug, more of like a serendipitous event. Chlorpromazine was synthesized by Paul Charpentier, and it was first used as a sedative by a physician for patients who are going into shock. And since there was a substantial amount of sedation, he had insisted some of his colleagues to actually do that. And the Val de Grace, it's a military hospital in Paris. Patient Jacques was the first person to actually receive treatment with chlorpromazine. And thereafter, there were clinical investigations at the St. Anne's Hospital. And in 1952, it came into the French market under the name Largactil, which is a short for large inaction. So this is also. So I just have 5 minutes, I think. So I think this is, as most of us as students have probably heard these names, have read about them, but I would like to actually focus on how we cannot hide from the fact that this diagnosis has been abused. This diagnosis has been abused by many political systems of the world, and that we must be careful and immune to allow systems to actually influence us in our practice and diagnosis because of the element of subjectivity that in psychiatry. So during the Nazi time, people like Rudin and Kalman was of the Kalman syndrome fame. They believed that it was a Mendelian inherited disorders. And in 1939, many of the German psychiatric hospitals under Hitler's order were asked to carry out a survey which established that 70,000 people would qualify for the goal of a program which is called Action T4, where they were actually killed in gas chambers. And more than that, they also actually followed a principle of eugenics, racial hygiene, where more than 132,000 patients with schizophrenia were sterilized. So this is some of the darker history of schizophrenia that people should be aware about. And this book by Protest Psychosis by Jonathan Metzger, it's a beautiful book. It deals with the Ionia State Hospital in Michigan, which diagnosed African Americans with schizophrenia and institutionalized them for their civil liberties. Many of us must have heard of drapetomania, a term coined by Cartwright, which hypothesized that drapetomania is the reason that African Americans fled captivity during the time of slavery. In Russia, there was a diagnosis of sluggish schizophrenia by Sneshnevsky, a diagnosis often used by Soviet psychiatrists against political dissidents. So, and similarly, the Montreal experiments, the infamous one by Donald Yu in Cameroon, based on his principle of psychic driving. This was a part of CIA's project MK Ultra, where they wanted to depattern unsound habits in people with schizophrenia and rebuild their psyche from the scratch. And so they were subjected to prolonged sedation followed by heavy doses of it. When I mean heavy doses of ECT, they received 3 to 4 ECTs in a day, such that they were in delirium. They used LSD. And following that, there were repeated audio recordings in order to reinforce positive messages, which resulted in substantial trauma to all of the clients who had undergone. One of the other, this thing is Rosenhan experiment, though there is a lot of critique. The students must read about the Rosenhan experiment and what it is. So all of these also led to a movement of anti-psychiatry that we should be aware of. This is David Cooper in above and Lang, who were two of the major figures. Cooper had actually coined the term anti-psychiatry. They all had their own descriptions of how schizophrenia arose as a pathology. We'll not go into that. And also, we must be aware of this gentleman, Thomas Sass, central key figure in anti-psychiatry movement. And as all of these, so all of these three people were gentlemen were psychiatrists, and they would insist that rather than anti-psychiatry, what they had a problem with is institutionalization and actually forced treatments. And so this is often what they were against. And so though they had their own theories and we may disagree with what they say, it's very important to understand these personalities for an understanding about where we stand now, all the dark chapters that have happened in psychiatry, which is something that I actually wanted to actually highlight in my presentations. I'll just take a minute again. And so for during these, which has led on to the new diagnostic systems, the development of the construct validity by the so-called neo-Kraepelinians, the very, very famous Robinson-Hughes paper, which talked about clinical disruption, laboratory studies, exclusion of other disorders, follow-up study, and family study as the major this thing of construct validity. And this led to the development of the Feiner criteria along with Winokur in 1972. And later, building upon this, Spitzer developed the research diagnostic criteria with the development of the DSM-3, which was a watershed movement in the history of psychiatric classificatory systems. I'll not go into much details about this. Yes, so what has happened is that the two syndrome concept, that is positive and negative symptoms, they were originated by Timothy Crow, and then Carpenter had talked about the deficit and non-deficit forms of schizophrenia. This is something that people should read. There were better instruments by which we could measure. Andreasen had developed SANS and SAPS. There were statistical techniques such as factor analysis and latent class analysis, which helped us to create a better listing of nosology. But then other schizophrenia spectrum disorders, that is schizoaffective delusion disorders and schizotypal disorders. So I'm just going through some of the terminologies that we should be aware in history of schizophrenia and more or less with nosology related to schizophrenia. So this is more or less with the recent ICD-11 and DSM. I'll just skip this part because it's time, and I'll just give the conclusion. So the efforts were always to prove schizophrenia as a reliable, recognizable, unitary, and stable object of inquiry. We have never actually been able to do that. This has been from the times of Kraepelin, what people have been trying to do. Research has borne out that it is a heterotypic disorder. History has taught us that our best teachers, all of the teachers of psychiatry, were able to tell a part of the story about schizophrenia. And so as mental health professionals, it is important for us to wield the responsibility that we are tasked with, uh, giving way to science, and more important, to the humanity, and vigilance that therapeutic states don't develop under our watch. And we should be very careful against other kind of political and difficult things coming into our way of diagnosis. Thank you.
Yeah, thank you, Dr. Jayakrishnan. I think it is a wonderful talk on historical aspects. You made us walk through the nosological aspects, how the concept of evolution, the controversies, the challenges,